So thank you for your patience, everybody. Most of you will know me, I hope by now. My name is Ros Saunders. I've put my full name there in case anyone wants to email me with any questions. So it's just rosalind.saunders at the usual. I mainly cover the Glenfield ITU. Some of you will have met me at the Royal because I cross-cover Dr. Lim also. And today, thank you, Zoe, for inviting me. I decided that I wanted to talk to you about fungal biomarkers. They're in inverted commas because by the end of this half hour or so, I'm hoping that you'll never actually say the word fungal biomarkers, because I would like you to be more specific in what you're asking for and to understand what the fungal biomarkers actually are and how we use them and how we interpret them. So this is what I want to go through, just a very brief overview of invasive fungal infections, talk about the traditional fungal diagnostics, and then talk about biomarkers, how they are used specifically for the fungi, and particular pitfalls. So invasive fungal infections are important because they have high mortality, high morbidity, and they increase length of stay in hospital. It's really important that we are able to distinguish an invasive fungal infection in a sick patient with colonisation, which is very common and occurs in many, many patients. So the commonest invasive fungal infections that you will encounter in the ITU setting is either candidiasis, which is candida in a place where it's not meant to be, or candidemia, which is specifically candida in the bloodstream. Less commonly, we would see invasive aspergillosis and pneumocystis. And then for the sake of completeness, I've listed a few of the other invasive fungal infections that from time to time we might come across, but they are pretty rare. So what's important to note is that a lot of the work on invasive fungal infections come from the haematology and oncology population. So the EORTC is the European Organisation for the Research and Treatment in Cancer, and MSG is a mycology study group, something to do with education. And because a lot of the definitions are tailored towards the haematology and oncology population, there was this working group that decided to try and work out what should be the diagnostic criteria specifically in ITU patients. There's a lot less research done in this patient group. There's a paper there that those who are interested can have a look at. It's fairly recent and it's free access. And I've very much summarised it here. But in order to have a proven invasive fungal infection, then you need to culture fungi from a sterile site. And for the sake of clarity, sterile site is anything where you would expect to take a culture and not find anything. So that would be the bloodstream, the CSF, the peritoneal cavity. That's to be distinguished from, let's say, the skin, the respiratory tract, where you will always grow something. So fungi cultured from a sterile site, or alternatively, if you have a biopsy, let's say of lung tissue, if you have fungal structures and they're invading into tissue, then that is also proven invasive fungal infection. We tend not to do that very much, so that's a definition that is used in post-mortem studies often. To have a probable invasive fungal infection, you need three things. You need a host factor, which I'll talk about in a moment, either clinical or radiological features, and mycological evidence. So the host factor is something that effectively immunosuppresses the patient or puts them at additional risk. And from the point of view of intensive care units, you can assume that most of your patients who are in intensive care for any duration of time, or any extended duration of time, will have at least one host factor. So it's things like having central lines, being colonised with candida, being on broad spectrum antibiotics. So you see straight away that a lot of your patient group would meet the criteria for having a host risk factor. Clinical and radiological features are, again, very broad. So it might be radiological features of, let's say, consolidation in the chest that is unexplained by a bacterial pneumonic process, or you can have clinical features such as fever that is not responding to standard or even escalated standard antimicrobial therapy. So in addition to both of those two, you need some sort of mycological evidence, and this is where the fungal biomarkers come in. So the mycological evidence might not be a fungus from a sterile site sample, but you might, for example, grow Aspergillus from a respiratory sample. On its own, that could be colonization, but in conjunction with the host factor and the clinical features, then that might be indicative of invasive aspergillosis. And things like beta-D-glucan and Aspergillus galactomannan can also contribute to the mycological evidence meeting that criterion. So the traditional fungal diagnostics are either microscopy or culture-based. So the background picture here, this is what Candida looks like on a blood agar plate. So white colonies with little feet that protrude out from the edges. The disadvantage of this is that it does take considerable time. We have to give the organisms the best chance of growing, put them on the right media with the right nutrients, and then just leave them in a nice warm place and see what happens, see what develops. So this always takes at least 24 to 48 hours. By definition, there's fairly low sensitivity because these are natural, alive, biological things and they don't always grow. Sensitivity is affected by prior antifungal use in the case of fungi, antimicrobial use if we're talking about bacteria. And depending on where the sample comes from, we need to interpret what the significance is of finding that particular fungus at that particular site. There are also potentially issues in the laboratory. So Aspergillus spores, for example, are everywhere. We are all breathing some in at the moment as we sit here and speak. And no matter how clean we try to keep our laboratories, from time to time fungal spores will settle out on plates as well. So that can also make interpretation somewhat difficult. For the sake of completeness, this is what Aspergillus fumigatus would look like on a specific fungal culture plate. And now we'll move on to the biomarker. So a biomarker is a really, really general term, and it actually just means something that you can objectively measure, which is related somehow to either a normal physiological process, a pathological process, or maybe response to a treatment. And the definition from the EMA excludes anything that's not objective, so how the patient might feel about their treatment. So even really simple things like measuring somebody's blood pressure could be counted as a biomarker. And there are many that are not just related to infection, so you'll be familiar with things like HbA1c, troponin, all of these things. And they're either used for diagnosis, for prognosis, or for monitoring a disease process. In infection, we use different biomarkers all the time. And really the distinction between a biomarker and a culture is that biomarkers detect organisms. They don't, it's not a method of growing them. So if you're trying to culture an organism, you are saying this organism has to be alive, and it has to be alive and viable to be able to grow. So all of the molecular methods that you're familiar with, for example, for the COVID testing, the COVID PCR, that is detecting COVID virus. It's not telling you whether that virus is able to replicate and represents an infection risk. Pneumocystis, we also diagnose using a PCR method. We can look at specific ribosomal DNA from the 16S part of the ribosome, which is preserved as a kind of housekeeping gene in many bacteria, just to detect whether bacteria are present. So you might have seen us use that sometimes in, for example, a pleural fluid that's culture negative, but we really want to see if there were any bacteria there at some point. And when you've found the 16S ribosomal RNA, you can then attempt to sequence it and find out what that bacterium is. So it can be very sensitive and it can detect bacteria that are already dead. The downside of it is it just gives you the name of an organism and it doesn't tell you what antibiotics it might respond to. Measuring viral load, that's also a sort of biomarker. CRP and procalcitonin, their responses to infection, Legionella and pneumococcal urinary antigen, and then of course the fungal biomarkers that we're going to talk about today. So at its simplest, these fungal biomarkers, it's a general term. It's a bit like saying to somebody, do some blood tests. Okay, we need to be a little bit more precise in what we talk about, but they are biological products from the structure of the fungus, often the cell wall, and they leach or dissolve into different body components where we can measure them and detect them. So the formal name for BDG that we always abbreviate it to, or often abbreviate it to, is 1,3-beta-D-glucan. Then we have galactomannan and cryptococcal antigen. So they're the main three that we use in UHL. And we'll work through each one of those separately. So before we do that, just a distinction between the fungal biomarkers and the traditional culture. So in culture methods, we're not able to put any specific numbers on how much of an organism is there. Maybe an exception with urinary cultures where we try to quantify how many colonies will actually grow per unit volume of urine. But if you're, for example, taking a respiratory culture, how much organism you grow depends very much on what the sample was that you took. Okay, how good was the sample? How much sample was there? How long has it been sitting around waiting for transport between sites? The culture methods, of course, as we've said, take a decent amount of time, whereas the biomarkers can be done fairly quickly, although, as you have seen later, need to be batched. Culture methods, your organism has to be living and viable, whereas biomarkers can detect organisms that are no longer viable. For culture methods, it doesn't distinguish between colonization and infection, whereas the biomarkers we'll be talking about today shouldn't come positive if you just have colonization. They are a marker of invasive fungal infection. Culture methods have lots of reasons for having false negatives, i.e. they have low sensitivity, and particular ones of relevance are prior antifungals in this case. And sometimes you can have organisms that don't grow on the particular standard media that we use. In contrast, biomarkers, fungal biomarkers, have lots of reasons for false positives, which we will get onto. So we use these because if you can detect an invasive fungal infection early and treat promptly, then that's associated with lower mortality, increased survival. We can also use them to risk stratify and hopefully reduce unnecessary use of antifungals. So the antifungal drugs have got issues with often hepatotoxicity, sometimes nephrotoxicity for things like ambisome, lots and lots of drug-drug interactions. So if we use too many antifungals where they're not needed, we do have the potential to cause harm. So it's very useful to be able to reduce those if we possibly can. Then the next point is in brackets. So we do use fungal biomarkers to monitor response to therapy to a degree, but in the literature there is very little agreement about actually what we would expect the response to be. So at a very basic level, if we measure a particular marker and it's falling and the patient is getting better, then that's reassuring. If the marker is rising or if the patient is not responding, then that's worrying. But there's not really very good evidence out there for how fast you want it to fall. It's not useful as a marker for how long the duration of therapy should be. And there isn't an absolute value at which we would say, okay, it's fine to stop now. So the patient groups that we use these tests for are carefully selected. And the reason they're carefully selected is because if you go fishing with your biomarkers in a population where the prevalence is low, you are going to get more false positives and a lower positive predictive value. If you pre-select your patient groups that you're going to use it for people who are at high risk of invasive fungal infection, then your population prevalence is higher and your positive predictive value is therefore higher. So just to remind me to say that a lot of the research about the cut-offs and use of these has really been in the hematological malignancy population, and they've kind of been adapted for the ITU population, but all of the research is really not optimized for the ITU population. We're kind of inferring from the hematology population. So just looking at Candida, because this is the commonest invasive fungal infection that you are likely to come across in the ITU setting. It's a yeast which normally colonizes the GI tract and the GU tract to an extent. There are many, many different species. So as clinicians, microbiologists have been very keen to make sure that they are still called Candida. But actually there's a group of taxonomy microbiologists who are more research-based, who have done sequencing of these organisms and actually assigned a whole bunch of new names for them, which the clinicians are trying to avoid bringing into use because it's just extremely confusing. So if you look at the literature, you might find all sorts of things like myrozyma for things that we used to call different species of Candida. So just be aware of that if you're doing any further reading about this. So Candida do have a propensity to cause local infections, as an example being oral or esophageal thrush or vaginal thrush. But in certain patient groups, they can invade and cause serious disease with high morbidity and mortality. Many of you will have heard the microbiologists on your rounds talking about candidemia, and we worry about it disseminating to other sites. So candidemia is when it's in the blood. It can get into the eye and causing candida or endophthalmitis. It can stick on heart valves causing endocarditis. And often the original source of candidemia in an ITU patient would be from the skin via a central line or similar. In addition to that, you can get ascending infection from the urinary tract causing a candida pyelonephritis, or maybe from a nephrostomy, and especially for the people at the Royal, bowel surgery, where there's contamination of the peritoneal cavity, you could potentially set up a candida infection there in what should be a sterile space. So the risk factors for invasive candidiasis is anything that will cause you to be immunocompromised. If you are known to be colonized, then that puts you at higher risk. If you have breaches of barriers, and if you've been on broad spectrum antibiotics. So just eyeballing down that list, you can see that there is most ITU patients would tick a few of those boxes there. And the picture at the bottom right, that's what a candida would look like on a gram stain of a blood culture. So they stain this dark purple colour, but it's the size and shape of them that help the laboratory scientists to say this is a yeast in the blood culture rather than a bacteria. So they're larger, they're more oval shaped, and if you can get two together with one budding off the other one, then that is what shows you that it's a yeast. So the most commonly used biomarker in our ITUs is the BDG. So that's a polysaccharide from the cell wall of many fungi, notably Candida, Aspergillus, Pneumocystis, but also many others of the slightly more obscure fungi that can cause invasive fungal infections. The pharmacokinetics of clearance of beta-D glucan from the system are somewhat variable between patients and not very well understood. So that's why using it as a monitor for response to therapy is not always helpful, because in some patients they're treated adequately for an adequate duration for, say, a candidemia, and they are better, but the beta-D just stubbornly stays high. So it's always putting together what the test is showing you with the clinical picture in order to understand what's going on. This is a test for serum. It's not useful in a respiratory sample because we would expect any respiratory sample to have some candida in it. And this test measures beta-D-glucan at picogram level, so that's 10 to the minus 12 grams per litre. So it's very sensitive in terms of the amount of polysaccharide that it can measure. So it's very easy for these samples to get contaminated. Yeah, the manufacturer's sensitivity is somewhere between 70 and 100%, but you'll note that the specificity is not very high there. In UHL, the ordering is beta-glucan antigen test only, so that's particularly for the Royal ITU population where you've got a bowel perforation. One thing I want to ask you, and you feel free to put it in the chat, is that I'm just embarking on looking at our ordering on Nerve Centre, and I will be providing the IT team with alternative phrasing for many of these tests. So if there is any test done by microbiology where the search terms that you use make it difficult for you to find the test you need, do please feedback to me, because it's an ongoing quality improvement project that I'm involved in. So I'm very happy to have feedback about that. So this is a serum test. And what's really important, and Dr. Lim wanted me to emphasize to you, is that it's really important to put the correct clinical details for the lab, because the laboratory staff have instructions to process it if the indication is something relevant. So if you put something like bowel perforation, query candidemia, query invasive fungal infection, query PCP, then it will get measured. If you write something like fever or routine in the clinical details, then it won't get automatically measured, and it has to wait for either Felicia or me to pick it up and look at what's happening with the patient and then give the lab instructions whether to measure it or not. And the reason we have to have that in place is because it can be anywhere in the whole trust that orders these, and sometimes people get confused and order the wrong tests, and we only have limited capacity in terms of the kits and the staffing to be able to do the tests that are really needed. They are not cheap tests to do. This is the Fungitel assay that we use locally, and I've just put this picture here to remind me to tell you that these are batch tests. So there's a whole tray of little wells that we use. You have to make up the reagents and use them within a certain period of time, a couple of hours. It all has to be incubated together. So we have one run per day on normal working days, which are the only days that we have adequate staffing to make this work. And if the run fails, if the standards fail, sometimes you don't get a result until the following day when we have to rerun them. So we'd expect true positives for beta-D-glucan in invasive candida infections, invasive aspergillosis and pneumocystis, and then the other rarer fungi that I listed on the earlier slide. In the literature, you might find something saying that beta-D-glucan is a pan-fungal marker. That is not true. It isn't in the cell wall of all of the fungi, and these are the notable exceptions. So mucormycosis, which is the gentleman on the right, is a mold infection in immunocompromised and poorly controlled diabetes. But this patient, despite having invasive fungal infection in the nose, the sinuses, around the orbit, wouldn't have a positive beta-D-glucan because the mucorales that cause mucormycosis don't have that in their structure. The picture on the left is Cryptococcus, which is a yeast with a capsule that's highlighted against this India ink in the background, and that also doesn't produce appreciable beta-D-glucan that would get you in the positive territory. In invasive candida infections, beta-D-glucan can become early before blood cultures, and in fact some cases blood cultures might not become positive at all because the sensitivity isn't perfect, and the positive and negative predictive value would depend on prevalence. But if you peg the prevalence to be less than 5%, then you can expect actually quite a good negative predictive value, but the positive predictive value is actually still pretty low. And you can increase the specificity and therefore the positive predictive value if you use 2 samples, which is why if you get an equivocal result or a positive result, you'll find a comment on the sample saying repeat it so that we can see if it's reproducible and genuine or not. Pitfalls is that it can persist for a long time, even if there's a proven candidemia. So the kinetics can sometimes be slow to decrease. The body clears it slowly. And the sensitivity actually depends on the fungal species. So we tend to use it as a for Candida, but not all Candida are the same. And in particular, these two species tend to produce less of the 1,3-beta-D-glucan. So sometimes the BDG result might be below cutoff for candidemia with those organisms. The main pitfalls, though, are the numerous false positives. So there are many, many reasons for there to be false positives. So for the Glenfield people, we have lots of cardiac surgical patients. So many of those will have a transient positive beta-D-glucan that is perhaps related to the surgical gauze and packs that are put in, or it could be the bypass, if there's anything with cellulose membranes or filters. So even some of the fluids that go in can give you false positives. So that's why Glenfield people, I'm always encouraging you not to do beta-D-glucan routinely in the cardiac surgery patients. There might be situations where a patient's been in for a long time and we're suspecting a complication when we would do it. But if you try to measure it on too many people who are at lower risk, we're just going to get lots of false positives and struggle to interpret them. False negatives, we've got those organisms that produced little or no beta-D-glucan that I've mentioned already. And just one caveat that although negative predictive values are high, if you've got a really high pre-test probability, so just as an example, if you suspect pneumocystis and you've got compatible radiological findings in a non-HIV patient, if you are really worried about something, even a negative beta-D-glucan wouldn't necessarily rule it out. So this is where you need to be discussing with your microbiologist about what it means. And the truthful answer is none of us are going to know for sure, but we find a way forward together and learn which other questions we need to ask and which tests, if anything, that we need to repeat. Moving on to galactomannan, it isn't a single molecule, it's a family of soluble polysaccharide molecules that form the cell wall structure of Aspergillus, but also many other fungi, notably penicillium, which again is a ubiquitous fungi, which most of you will be able to find on your fruit or in your bread bin if you've been on call for a weekend and haven't cleaned away. It's released during the growth of the fungus and at the tips of the hyphae. So if you get a positive, then that is suggestive of active growth. Then because it's soluble, it goes into the serum and other body compartments and is detectable. The test we use is an enzyme immunoassay, which basically means you've got a monoclonal antibody, which is stuck in a little micro tray, and that will capture the antigen, which is the galactomannan. And then after various washing steps, you then put a chromogen in, and then if the antigen is present and still captured, there will be a colour change, which will be detected by an automatic reader, and then you come out with a number, which is related to the optical density. The cutoffs, again, have been defined in the haematology population. So in the kit insert, the cutoff for a positive result is 0.5. And because of the way that the laboratory works, any test that is greater than 0.5, whatever sample type is in, will be reported as positive. You should see a number as well for the galactomannan tests. And for the bronchoalveolar lavage, there's a different cutoff in the literature to what's in the manufacturer's recommendations. So actually, we only consider a bronch to be positive with a value of greater than 1. The serum galactomannan is useful in the haematology population and in influenza, serious influenza, kind of ECMO level influenza particularly. In many other patients, you would get a negative. The bronch is more useful even in non-neutropenic patients. And then for the sake of completeness, in COVID at the Glenfield, we did a lot of non-directed bronchoalveolar lavages. So formally the test isn't validated for that, but the guidance for COVID-associated pulmonary aspergillosis did have some use of NBLs to interpret, because it wasn't always possible to do a full bronch. So at the moment, as it stands, and this will be changed if I get my way, the only way you can order galactomannan is to type fungal biomarkers, and it previously was called galactomannan. So that is something that I'm intending to change, and you'll be able to order either beta-D-glucan or galactomannan, or both. So when you order this, it actually calls up beta-D-glucan and galactomannan. So sometimes we're doing beta-D-glucan when it is not needed. Again, clinical details for the lab, you need to put something specific here related to the patient's risk factors for a fungal infection, rather than writing things like routine or fever. And your specimen type should be either serum, BAL, or non-directed bronch. So the sensitivity and specificity, it depends very much what patient population you look in. So it's different for children and adults, it's different for haematology versus non-haematology. So I've just kind of lumped them all together as much as I can. So sensitivity approximately 0.8 and specificity approximately 0.85. And then for adults, if you calculate the prevalence of invasive fungal infection to be 5%, that again gives you a rather lowish positive predictive value and a pretty good negative predictive value. If you have a, for example, haematology patient who is already on mold active antifungals, things like posaconazole as prophylaxis, then this test becomes considerably less sensitive. So we just need to be aware of that. True positives would happen in invasive aspergillosis, and that can be associated with influenza or COVID. Just to note that for influenza, you're more likely to get a positive serum galactomannan. In COVID-associated aspergillosis, it was actually fairly rare to get a positive serum galactomannan, but you could get, we did often get positive BAL or NBL galactomannans. Then there's the other rare invasive fungal infections that I wouldn't expect to come across very often, if at all. And then false positives, again, there's a massive list of false positives. So galactomannan is within foods, cereal products, milky desserts, things like that. If you have intestinal mucositis, then some of your food products can translocate, or the galactomannan, the soluble part from your food, can end up in the bloodstream transiently. It's been known to contaminate some batches unpredictably of antibiotics, notably tazocin and coamoxiclav, and it's because penicillium is actually used in the production process of these antibiotics. So you can get a transient positive that actually takes several days to clear. For the ITU population, I guess the one to know about is electrolyte solutions. I don't know if you use Plasma-Lyte, but classically that can give you false positive galactomannans. And of course, it's always possible to contaminate your sample, or it's possible for us to cross-contaminate samples within the laboratory. False negatives, you can get galactomannan that is present but below the cutoff. If your patient is not neutropenic, you might have a level below the cutoff as well. And the sensitivity of serum galactomannan in COVID was something like 20–25%. And again, there are many different species of Aspergillus, and some produce a lot of galactomannan and some produce less. So that also has an effect. The ECIL-9, so that's the European Commission for Investigations of Leukemia, they say that you can use galactomannan to monitor response to therapy, but actually it's more to monitor lack of response. So if you're on treatment for some considerable time and your galactomannan is still rising, then that's a poor prognostic sign. And we'd be wanting to look into things like whether there was anything else that we could do in terms of source control, or perhaps switching to another antifungal because there might be resistance. Unfortunately, resistance testing in things like Aspergillus takes a long time. We have to send the samples away to Bristol. So sometimes we have to empirically switch the antifungal therapy if the patient doesn't seem to be responding. And then for completeness sake, and I won't talk about this very much, the third biomarker that we use for fungi in UHL is the cryptococcal antigen, which is a very quick to do lateral flow test that detects all of the cryptococcal serotypes. It can be done on serum or CSF, and it has very high sensitivity and specificity. There are many other fungal biomarkers which we don't routinely use in UHL, but we can send away for at least some of these to reference laboratories if there is a particular need. And this is changing all the time, but for a low volume test, as in for ones that we don't do very often, it's usually not efficient in terms of finances or staffing to have these tests available in-house when they are rarely needed. So routine use within UHL, the learning points for the LRI team: if you've got perforation or bowel contamination during surgery, it's beta-glucan antigen only that you send. Please do not send fungal biomarkers because that will do an unnecessary galactomannan. And please put as your clinical details bowel perforation. If the information on the form in the clinical details is wrong, then it might not be tested when you expect it to be, and it might rely on one of the microbiologists picking it up and sending it back to the lab for testing. So help us to help you by making sure that your clinical details are accurate. And if it's the nurses that take these samples, if you could feed that back to the nurses as well, that would be enormously useful. Thank you. So take home messages from this is just to be aware that the presence of Candida or Aspergillus on samples doesn't automatically mean that you have to treat it. You have to think about what that sample is from. Is it part of the normal microbiota there? Does it represent colonization, or are there clinical features to make you suspect that there is invasion, infection? So this is why you might find me or Felicia asking, let's say, for a pleural fluid: was this from a pre-existing drain, or was this from a freshly inserted drain? Because a freshly inserted drain into a sterile site, then if we grow Candida, then that's significant. But if it's a drain that's been in for 3 weeks, then they often get colonized. When you order these tests, just think about what question you're trying to answer. And hopefully by the end of this, you'll know which test you need. So are you looking for invasive candidiasis, in which case you need beta-D-glucan? Are you looking for invasive aspergillosis, in which case beta-D-glucan and galactomannan can be helpful? And the other message is just make sure that you are aware of false positives. Please don't send beta-D-glucan in someone that you've just put IVIG into. And there are nuances in the interpretation. The clinical picture is really important to work out what's going on, not just the test results. So if in doubt, please do discuss with your local microbiologist. So that's all from me. I'm very happy to take questions. I haven't been monitoring the chat because I'm on a different screen. So if there's anything there, then do shout out.
Hi, Ros, it's Sarah.
Hi, Sarah.
Just had a little realisation. So we switched to Plasma-Lite wholesale across ITAPs in September 2021.
Mm-hmm.
What's the data comparing before and after? How significant is that false positive galactomannan association?
So it's from the manufacturer's literature, I think, the Plasma-Lite. I'll dig it out for you. Because we don't encourage testing we don't do serum galactomannan very often, actually. So in the Glenfield, at least, it's part of the SARF screen that we do on admission, which is probably before Plasmolite goes in, although it depends on what they had in the referring hospital. We have had one case very recently where they had a positive serum galactomannan that was then convincingly negative a few days later. So that patient did get a short run of ambisome. But we looked for aspergillus at other sites and didn't find it, and they got better a little too quickly. So that one I was happy to write off as a false positive. But I don't think we've got enough data to say this is before and this is after. And also I suspect it might be, if it's like the antimicrobials, it may be batch dependent.
Yeah.
So there is some literature that says that if you seem to be getting things that you think are false positives, you should go testing your fluids that you're putting into the patient. But actually, it's often not practical to do that. And as a laboratory, we have to be very careful that we only run tests on sample types that are validated. So we could try and measure in antimicrobials or plasmolites, but actually we don't have the right accreditation to be measuring those things, so we wouldn't be able to formally report it, which puts us in a slightly awkward position.
Okay, interested. Good to bear in mind in the future. Thank you.
Okay, everyone's gone quiet, so I'll let you get on with your journal club, but any further questions, just feel free to email me.
Well, thank you very much for that.
Thanks, Mike.
That's brilliant. That's brilliant.
My name is Vivek. I'm one of the clinical fellows at IT here. I'm going to basically, we've got an article which is looking at linezolid against MRSA. So essentially, I'm part of this as the fight against MRSA and the battle of linezolid. This is a journal article that I've reviewed, which is, sorry, is that okay? Effectiveness and safety of linezolid versus vancomycin, teicoplanin, or daptomycin against MRSA bacterium, a systematic review and a meta-analysis from our following authors. And it is rather recent publication, which was on the 2nd of April in 2023. So the title is, as you can see, essentially, the journal was in antibiotics, and we're going to try and critique craziness, essentially. What we're going to sort of do is just start by setting the scene, go through the methodology, and then a summary of the results, and then a conclusion, and then whether it will change our practice or not, essentially. The problem with MRSA, it causes mortality, especially with bacteremia, around greater than 20%. There's limited treatment options, we're already aware. And currently the first line diagnosis is vancomycin and also daptomycin as well. So essentially the question we're asking, should we consider off-label drugs? Because most of these drugs haven't been, considered for MRSA at the time of when they were being investigated. So anyone has a clue what this drug is? Take a guess. It's not rocket science because it's anyone in LRI?
Is it vancomycin?
It's actually linezolid. We're obviously researching linezolid. So yeah. All right. So linezolid is basically oxidized antibiotics. It's a bacteriostatic protein synthesis inhibitor, and its bioavailability from oral to IV. They say it's 100%, but obviously we know that there's going to be some drop of bioavailability between PO and IV, but it's near enough close to 100%. And possible reasons, basically why we're not using it is there's limited data, delayed application and treatment, drug-drug interaction, and also we've got this notion of myelosuppression as well, which we've seen in some patients here at the LRI as well. And there's also this dogma that bactericidal antibiotics afford greater clinical effectiveness than bacteriostatic, essentially, antibiotics. And this was obviously found in an article which was busting the myths of static versus cidal by a 2018 article that was published. I could send this PowerPoint out later. Other characteristics that are important as well that the paper talks about is pharmacokinetics is obviously important, tissue distribution and penetration as well. So it was saying there is no difference between bactericidal and static, basically antibiotics. And the things that are more important are the pharmacokinetics and the tissue distribution and penetration. So the UK MRSA guidelines currently stand, they recommend linezolid as an alternative to the first line drug when vancomycin is counterindicated. And then they recommend that teicoplanin and daptomycin are used only when vancomycin and linezolid are. So the hypothesis of the paper is that linezolid would afford similar effectiveness and safety to vancomycin, teicoplanin, and daptomycin in terms of mortality rates, clinical and microbiological cure rates, and the incidence rate of drug-related adverse effects. How their methodology was essentially they did a literature search. They used 4 databases: PubMed, Web Science, Cochrane, and clinicaltrials.org. They basically reviewed the titles and abstracts of the 3,121, and they managed to narrow it down to 3,074. And then after that, they basically further narrowed it down by actually reading the titles and the abstracts, down to 47 articles. And then the 47 articles, they read the entirety of the 47 articles, and they managed to get it down to 9 studies, which met inclusion criteria. The inclusion criteria was documented slightly further down, and they used PICO, which basically looked at patients, and the patients they were looking at were adults predominantly. So one of the papers starts from the age 13 and above. The intervention they were looking at was linezolid, and they were comparing it to vancomycin, teicoplanin, and daptomycin. And the outcomes essentially that they were looking at. The primary outcome for the paper was mortality, and the secondary outcomes were clinical cure, microbiological cure, length of stay in hospital, reoccurrence, 90-day admissions, and drug-related adverse effects. But you'll find that there isn't much results in regards to drug-related adverse effects on the actual paper, because they only had one actual case study that was it actually showed in sort of drug-related adverse effects. The others didn't document it. So this is how they narrowed them down. Essentially, it's just a more diagrammatic way of looking at it. For anyone, I'll keep it on the slide just for a few minutes, just so people can process it. So moving on. Okay, this is a very cluttered slide. So do try, and I'm going to summarize it a bit better when we talk about limitations. But it was the only way I could get it all on there. This is essentially how they did the systematic review and how many papers they got. That was 9 papers. And there was a lot of data that was missing. NR just essentially not reported on the paper. Like I said, I will summarize it a little bit better as we go through the paper, as we go through as well. So there was 9 studies. 2 of them were randomized controlled trials. One of them was a pooled analysis of 5 RCTs. One of them was a subgroup analysis of a randomized controlled trial. And then there was 5 case-controlled cohort studies as well. In total, the amount of patients that they looked at was 5,328. The randomized controlled trial, they had roughly around about 111 patients who got vancomycin and 93 patients who got linezolid, and no patients got teicoplanin or daptomycin in the randomized control trials. And the case-control cohort studies, now this is something just worth noting. The amount of patients that got vancomycin was 4,783. The people who got linezolid were 200, and teicoplanin were 27, and 114 with daptomycin. So, yeah, as you can see, there's a lot of numbers that got vancomycin as opposed to linezolid, especially on the cohort studies. There were 6 studies that basically went through and explained about vancomycin adjustment, trough levels essentially. However, no studies mentioned the loading dose of vancomycin. And no one specifically talked about teicoplanin optimal dosing, as we were talking about earlier as well, about doing levels of teicoplanin in the labor. So the primary outcomes, was mortality, and essentially the difference, it was 36.6 on one group and 36.2 in another group. As you can see, there's not much difference, and even just analysing the the data. So the top data, so A always represents the randomized control trial, and B was the cohort studies that were carried on, the case studies that were carried out. And each of them, as you can see, the diamond crosses the line on each occasion, so there's not really much significant difference. Clinical cure, once again, similar in terms of significance. I'll just give people a chance to process them at least. Okay, microbiology cure rate as well, once again, that was a secondary outcome. Once again, slightly more pulled on the bottom chart, as you can see, but otherwise still crossing the line, so not showing any clinical significance. And this is length of stay in hospital. The article did talk about they were expecting a difference, seeing as you can convert linezolid to oral, as the bioavailability is similar. However, they didn't find there was much of a difference, really, to be fair, between the two groups. This was 90-day readmission. Once again, not much difference as well. So as summary, basically, so in primary outcomes, not much significant difference basically between the mortality between the two groups. The secondary outcome, once again, not much difference. And like I said, the adverse effects, they did talk about them. There was only one real article that really mentioned it. So they didn't really go into much detail about it in regards to it either. So the limitations of this study. So vancomycin, there was far more people than linezolid, teicoplanin, or daptomycin. So is it really comparable? Was my question that I asked myself. The population as well, they use all over the world. So, you know, the type of strain that we're targeting, is it going to be the same everywhere around the world? Was my question that I was asking myself as well. And then obviously the population as well. They were looking at mortalities. Now, they haven't mentioned any comorbidities or whether there were similarities between the groups or the data they were comparing. And some of them even started at the age of 13, as mentioned previously. The source of infection as well. So they just looked at MRSA bacteremia, essentially. The source could have been anywhere from lung to tissue, essentially. So it wasn't exactly clear as well a lot of the time where the source was. Comparing randomized controlled trials, inclusion criteria between different papers. There's not always an overlap between the inclusion criteria as well. So also that needs to be taken into consideration when looking at that limitation. And there was actually basically one of the randomized controlled trials basically looked at Staph aureus bacteremia. So I'm not sure whether they were truly methicillin resistant. And the other one looked at MRSA pneumonia solely as well. The other thing to mention is that some of them, as a result of hospital guidelines, were starting on vancomycin, and then later when they were recruited onto the trial, they were changed over to linezolid, daptomycin, and teicoplanin as well. So they may have had a dose of vancomycin prior to all of this. MRSA bacteremia can also cause, obviously, as we're aware, joint infections, and also can cause infective endocarditis as well. So was there any source control that was carried out as well? That wasn't either documented or specified either. So in conclusion, basically, linezolid can cause resistance. I mean, we will soon enough, if we start using it, we're going to start getting resistance to linezolid as well, as we've seen with other antibiotics like VREs. Adverse effects as well was not really well studied in this review. Would I change my practice as a result of it? I don't feel like we've won the war against MRSA here, but I do have a lower threshold to prescribe linezolid, seeing as it's not got, you know, the mortality risks are about the same, even though the comparable data is not exactly the same in terms of population. But I would have a low threshold to prescribe linezolid in this case. I wouldn't change my entire guidelines of practice based on this sole paper. Any questions? Thanks, Kevin. Hit me.
In what scenarios would vancomycin be contraindicated?
What scenarios is vancomycin contraindicated? I don't know, to be honest, answer that. Maybe you can answer that question better than I can.
Well, allergy, there isn't many, really. Yeah. I mean, you can still use it in renal impairment. It's more difficult. Optimized dosing, and you can definitely use it for filtration. So there isn't many circumstances when it's properly contraindicated. Based on that question you put at the end, is using linezolid. So basically, the opportunities are, you know, to verbally switch across based on contraindication.
Fine. So just to reiterate the question, it was when would vancomycin be counterindicated, and essentially the answer for that was that there's not many situations where that would occur. Essentially, unless there was a true allergy. The only other thing is that whether you were considering changing to oral and again,
Yeah, sometimes to optimize the therapy rather than contraindication.
of course. Any other questions at all? No? All right. Well, thank you for listening.